session of Public Health 101. Today, we're going to be learning more about healthcare equity from Allegra. Allegra, if you could just introduce yourself and your position, and then you can get started.
Sure. Thank you, Jen. I appreciate it. So, hi, folks. Small group today. I am Allegra. Like Jen said, I am the Chief of Healthcare Equity in the Health Equity Institute. Today, I'm going to be talking about the bulk of my work, which is the Health Systems Transformation Project, Social Determinants of Health Investment Strategy. And so, Jen, if it's okay with you, I will jump right in and get going.
Yes, perfect.
All right. Awesome. Can everyone see my slides? Jen, can you see my slides?
Yeah.
Okay, great. Okay, so what is the Health Systems Transformation Project, Social Determinants of Health Strategy? It's a very, very long title, but it's pretty simple beyond that. So studies show, and folks on the call know this already, that 80% of our health is determined outside of the clinical setting, but still most of our healthcare resources remain within the clinic. And what this means is that sick care is the norm and preventative care is fragmented and under-resourced. So the Health Systems Transformation Project, SDOH investment strategy, I'm going to stop saying that in full again, is Medicaid's way of rethinking this and about investing money into the community. If you want to see the full strategy, you can go to this link here when I share the slides. And Jen, I assume you're going to share the slides with folks.
Yes, I can.
Great. So within this document, there are 4 different investment strategies: the Road to Equity project, a participatory budgeting project, an e-referral platform called Unite Us, and then lastly, community health teams. I am very much involved in the Road to Equity and PB project and do a lot of work with Unite Us, but I don't with the community health team, so that's the only one that I won't be covering today. I'm going to start with Road to Equity. What are the goals of Road to Equity? They're listed on the left, so I don't need to read them all verbatim. But I will point out that the first goal talks about enhancing place-based teams. And team building is really the crux of this project. So the members include community health teams, health equity zones, accountable entities, people with lived experience, clinical partners, and other CBOs if they choose. So after they build these teams, the idea is that Road to Equity strengthens their ability to address equity issues at the community level. And we work with teams to do this by using an evidence-based tool called Pathways to Population Health. We're getting support by also national experts to use this tool. They are the Wellbeing Equity in the World, or WE team. On the right, you can see kind of the cycle that the first year of the project went through. The first top left corner talks about building your team, which I just discussed. And then it says, get proximate to the community, develop an action plan, take action to advance equity, and evaluate, learn, change, and sustain. And then we start back to invigorate the team if need be. What do we mean by this, though? I mean, it's a little buzzwordy, but there was very specific deliverables that went within each of these parts of the cycle. And so, for instance, for Get Proximate, we worked with the teams to map the assets for their community. We completed what's called a 7 Stories project, which is the teams going out and talking to people that are affected by this inequity and other health issues, to make sure that they are correctly working with the people that they're trying to serve. They brought data together from the accountable entities and from the HESs to really make sure that they had population level, but also patient level information. And they did risk stratifications. And then as we got further along the cycle, the biggest part was for the team to develop an action plan. So to take all the information that they learned from the first few months of the project and to put it into a plan to actually reduce this inequity in their population. All right. I am going to the next slide. There we go. So a really big part of the road to equity is this portfolios of pathways to population health. And so each team, when they were developing the action plan that I mentioned in the last slide, were doing so keeping in mind that they had to have actions within all 4 of these portfolios. And so on the top right is the downstream portfolio, or P1, physical and mental health. This one is really working with the highest risk patients who already have medical conditions and making sure that we're doing everything we can to support them. If you go down, there's the midstream, or P2, social and spiritual well-being, which is looking at the medium and rising risk folks and making sure that we are doing whatever we can in terms of addressing their social needs and their spiritual needs so that they don't end up in this P1 or high risk group. Then if we go over, I know it's a helix, but to the green P3, that's community health and well-being, or our upstream community conditions portfolio. And the idea of that one is to work with folks that are not yet in the medium to rising risk group, but who are in communities where that risk is higher, and to make sure that those communities support them and prevent them from becoming unhealthy. And then P4 is the communities of solution. It's in that place that we look at policies and systems that have, been around for a long time because of things like racism, and making sure we can address those root causes so that, again, we don't end up in a situation where folks are in the P1 space. And so as an example, I know that's a little bit convoluted, so all of the 6 teams made action plans. I pulled out a few examples from the 02907 action plan so that we could walk through this. So the 02907 action plan is about reducing asthma within the 02907, which is the West Elmwood community of Providence. They specifically, for P1, are hoping to make sure that they reduce the number of people going to the hospital for asthma by 50%. And so a P1 strategy that they had was to hire community health advocates, which is their name for community health workers, and to work with high-risk patients that have already been hospitalized to understand why and to make sure that they don't become readmitted. If we go down to P2, which again is the social and spiritual well-being, they wanted to reduce the risk of asthma clients that go to the hospital at all by running kind of programs that will make their houses healthier and make it easier for them to not be triggered from asthma. And so those 2 programs that they listed were the HARP, which is the Home Asthma Response Program out of Rideau. I hope Ashley's come to present to you because that program's awesome. And then also the Breathe Easy at Home Healthy Housing Intervention. Moving over, so there's the portfolio 3 work. And again, this is like how we can prevent people from getting asthma in the first place, and particularly for getting asthma where they end up in the hospital. So for this team decided to host community education efforts with the American Lung Association and residents to inform them about air quality issues and encourage advocacy, and then also to support efforts to conduct air quality monitoring in and around the HES. And then lastly, for portfolio 4, and again, this is how we can address root causes and things like racism. This team is partnering with another team, the Central Providence HES Road to Equity team, to train community health workers, or as I call them, advocates, and community advocates on land use, zoning, and upcoming comprehensive planning process in the city of Providence. So their goal is to make sure that we don't continue to, I'm not sure if I'm going to find the right word, don't continue to say that it's okay that these zoning practices, which are, based in racism and disadvantage certain populations over other, continue to go on without being questioned. And so again, that's looking at something that is the root cause of why there's asthma triggers in certain communities more so than others, and trying to build up the capacity to address that. So I was just talking about the West Elmwood team. They're number 3 on this list, but again, there are 6 teams that are part of the Road to Equity project: Pawtucket Central Falls, East Providence, West Elmwood, Washington County, Woonsocket, and Central Providence. All of their focuses are listed here, but this is really just like the tip of the iceberg. They've developed, and I should say they've developed action plans, and for year 2, that's going to be their work. So year 1 just finished. This was on the regular fiscal year, and we were doing alongside the implementation a lot of evaluation of this project. And so one way that we were looking at whether or not our work was going well was using this compass tool. I am a big fan of the compass tool. And what it looks like first and foremost is whether their skills to improve equity in communities are strengthening as a collaborative, and if their collaborative is getting closer to each other. And so if anyone's interested, the link is in the slides for when you have it afterwards. And that will show you the full compass tool. This is just a little sample of it. What did we learn? We learned a bunch, but I picked out a few things that I thought were exciting. The first question was, how were capacities related to population health and health equity built over time? And did teams demonstrate improvement to equity behaviors? And the answer was yes, which is always good. The Road to Equity teams did demonstrate improvement in capacities over time. So if you look at the graph, what you'll see is the first line, the darker one, is when they took the survey the first time, and the pink one is when they took the survey the second time. We also asked whether the teams deepened their collaboration over time. And yes, we found that this also happened, which was really, really great. And so, and these are a little bit, I'm wondering now, I'm questioning my choice of, of graphs because this was just 2 of the 6 teams, and 5 of the 6 teams for both this and the last question showed improvement over time. The exception was Woonsocket, where they were a little bit stagnant. So my mistake with that one, but the full report will be available to people, so that's okay. And so what you see here, if you're looking at changes in collaboration for West Elmwood, is that in the beginning, like the median feeling was that they were somewhat connected and there was a lot of variation. And that was at the beginning of the year. And then, oops, sorry. And then when you move to the end of the year, people thought they were much more connected. The average went from a 6 to a 9, and there was also much less variation. Is there anyone that has a question for me before I go on to the next project? Okay, hearing none, I'm going to go on to number 2. So again, the Health Systems Transformation Project, Social Determinants of Health Investment Strategy, has 4 strategies. The second one that I'm talking about right now is the Participatory Budgeting Strategy. So PB is a democratic process in which the government agencies funds a facilitator who assists members of the community to decide how to spend public budget. I'm not going to read the whole thing, but again, that whole document is online. We selected 2 health equity zones through an application process and ended up funding Pawtucket, Central Falls, and Central Providence opportunities. We gave each has $450,000 for community improvement projects, and then CPO leveraged an additional $550,000 from Blue Meridian for a total of $1 million that will go out to the community. So I wanted to stress, and I put this slide in here for this reason, that PB is not something that Medicaid made up. It's not something that Rhode Island made up, but it's actually a process that runs not only all over the country, like you can see on this slide, but has run internationally as well. And even though there's a lot of individualism within the way that steering committees are created and the way that projects are ultimately funded, there is also there's also a very specific process for running this. And here it is. So again, like I said, this is something that runs all over the world and has this process almost universally. The first thing is that community members come together to design what the process will look like. And that's a steering committee that represents the community and creates rules for engagement. Then the larger community brainstorms ideas. They do this through meetings with residents, online tools, which we're going to have in Rhode Island, community forums, etc. These ideas then go to another group separate from the steering committee called the budget delegates, which is again representatives from the community. And then they take the ideas that community members proposed and they develop them over the course of several months and with subject matter experts into full-fledged proposals that are possible to achieve and that include the budget for how much it will cost. And then they put this back out to the community for a vote, and residents vote on which proposals that they want to fund the most. Of course, the winning projects get funded, which is when we're going to all be jumping for joy. And then in a lot of places, and hopefully in Rhode Island, though the funding doesn't exist yet, this process will start again. What makes this process in Rhode Island somewhat unique is that because it's funded by Medicaid and because it's under their social determinants of health strategy, it's really geared at addressing social determinants of health. And so we went through the health equity indicators that the Department of Health has put out. And within those, there's 5 domains. And we made sure that it was very clear that this process was to involve projects that will support the improvement within those domains. So I don't need to go through all of those because those can be found online, and I will again share the link. But that's like looking at things like community resilience, the physical environment, access to healthcare, and making sure that there's no populations or groups of populations, less able to achieve things than others. So PB's proven to work, right? And here are a few things that it supports. It opens up governments and makes it accessible to people who are facing historical barriers to participation in voting. That in and of itself is an health equity indicator that we're trying to address, so that's pretty exciting. It generates more equitable and effective government spending, leads to greater confidence in public institutions, opens a gateway to civic engagement that creates a path to lifelong participation and has shown to improve voter turnout. Very excited about that. Supports new community leaders as people who participate in PB and gain more confidence in becoming civically engaged. Expands financial literacy, lose my words today, and civic opportunities for residents. And it has improved health outcomes, or been proven to improve health outcomes, where PB is linked to lower infant mortality rates. I want to circle back to the idea that I in the beginning, that my role with the Health Systems Transformation Project is really about bridging the clinic and the community like we were doing in Road to Equity. And that's still something that carries through to the Participatory Budgeting Project. And so there are quite a few Medicaid AE attributed members, so folks that are designated to a specific AE but have the Medicaid insurance, in those populations that we are running the PB process in. So in Central Providence, there's almost 35,000, and in Pawtucket Central Falls, there's over 30,000. So this PB project, beyond doing all the cool things that I talked about above, is really useful in making sure that the accountable entity what their communities want and what they believe will support them best in getting healthier. It's an opportunity for the AEs to see, the projects that are proposed necessarily all get voted on. And so the AEs will be able to see things that were runner-ups runners up, I'm not quite sure what that. Projects that were close but couldn't get funded because there's not enough money, and they have the opportunity to potentially invest and or advocate for their patients in that regard. See if I missed anything. So we are always looking for ideas for how accountable entities can engage in the process. And so I did leave this other ideas highlighted because it's ongoing. And if people have thoughts, then email me, please. All right. Last project that I will be discussing today is Unite Us, or the Community Referral Platform, CRP. So what is this? I'm not sure. Some folks have definitely heard of this and been very involved in the Unite Us conversations, and others have never heard of it at all. So just in case, broadly, Unite Us is an e-referral system that allows for closed loop referrals between clinical and community-based organizations, and also amongst CBOs themselves. This is really important because it allows for clinics and community-based organizations to more holistically work with patients. So Medicaid, EOHHS and Medicaid specifically have a contract with Unite Us. And this right here is what's covered under it. So, not only is it important for care coordination and to make sure that when someone is referred from a clinic to a social provider or other, that they actually receive the services that we're aiming to have them receive. But this also helps us look at the landscape of social services in Rhode Island statewide, and to see if there's any issues in, capacity of the service providers, the ability for clinics to refer to them, and also whether there's issues with certain populations accessing it. And so anyone from RIDO or any other state agency that's under EOHHS is covered to be on this platform and will have access to the following things: a network activity dashboard and a health equity dashboard. The network activity dashboard is the one that will tell us any sort of population trends that we're seeing. And then the health equity dashboard will let us know if there's any barriers for certain populations reaching certain resources. And lastly, my favorite part of this tool is that I use this tool for quite a bit when in my other job leading the Central Providence Health Equity Zone for a few years. And it's super beneficial for community-based organizations as well. They're the ones that are using it to make lots of referrals and to track their work, but they also have the capacity to regularly download their data. And so using this data in aggregate, organizations like this can advocate for the community and inform programs and policies that will improve the health of those neighborhoods. And they're able to do this in real time. So when I was at one neighborhood running the Central Providence Health Equity Zone, I was able to bring data back to the health department weekly, and it actually ended up changing some of the course of the work we were doing for COVID as a result. Let me see. And that is my last slide. I didn't realize it was because I got swept away in my presentation. So thank you very much. If there's questions, I will take them. And if not, then I'm happy to answer them via email. Jen, should I stop sharing?
Yeah, you can. It looks like we do not have any questions in the chat. Thank you so much, Allegra, for doing a deep dive on healthcare equity. Is really interesting.
No problem.
And I didn't realize other people in the department had HSTP funding, because the Academic Institute also has HSTP funding. But thank you so much. This is great.
Yeah, it's my pleasure. And feel free to share my slides when you share the recording. I don't know how you plan to do that, but
Perfect,
welcome to do that. All right. Take care.
Bye-bye.